Okay, I guess we could call the meeting to order. It looks like it's 6 or a little after, and it's our annual work session with the Assembly and the Hospital Board. So with that being said, will the clerk please call the roll?
Mark?
Here.
Cindy?
Here.
Bob?
Here.
Nancy?
Yes.
Kurt? John?
Here.
Jay?
Okay, Jay and Kurt are excused. And we have some members of the hospital board with us today. Could you please introduce yourself so we can get you on the record? And the CEO, Liz.
Liz Woodyard, CEO.
Tim Kahneman, board member.
Steven Samuelson, board member.
Kathy Reamer, board member.
Marlene Cushing, board member.
Okay, and we have other people with us in attendance today from the hospital facility as well. So now it's time for the voluntary Pledge of Allegiance. If you rise and face the flag. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Okay, well, looks like we have a PowerPoint here. We have the next thing on the agenda is a report from the hospital, so we'll start with that. However you guys would like to proceed.
Okay. Well, thank you very much for the opportunity to be here with you this evening and to kind of give you our annual report of how we're doing and what we've been up to this year. And so tonight we're going to just go through an agenda, and just this is who we have on our board and the staff that will be presenting tonight. So, and I'm just going to go through at a glance, just give a little overview of critical access hospitals and kind of where we're at in the nation and in Alaska. And then Jennifer Briner will talk about the services that we offer. Doran's going to talk about our financial status. And then Tim will end with the board perspective. So I just would also like to ask that you hold questions until the end, and that way we'll leave plenty of time for questions and answers. So if you do have any questions, just kind of keep them in the back of your mind until we're done. And we also do have handouts for you too, and we'll give those to you at the end of the presentation. So, all right.
Thank you.
All right, well, at a glance, throughout the United States, we have about 5,700 community hospitals nationwide. And that number kind of varies depending on what source you look at, whether it's the American Hospital Association or a state survey, because sometimes tribal hospitals are included in that number, military hospitals are in that number, but this is just community hospitals nationwide. Of those community hospitals, 1,325 are critical access hospitals, and that's what we are. Hospitals in Alaska, we have 23 hospitals plus 3 standalone nursing homes. And in Alaska, of those 23 hospitals, 13 are critical access because we have so many rural communities. And nationally, over the past few years, 47 rural hospitals have closed. That's about within the last 5 years. Last year alone, 10 critical access hospitals closed, and 283 are on the brink of closure. And that's just because of change in maybe the population of the town, maybe funding changes, and just challenges of keeping a hospital going. And right now, 41% of all critical access hospitals are in some type of financial stress or problems and are suffering from a financial loss. So that's just nationwide kind of where we're at. Our hospital is a non-for-profit critical access hospital. So any money that we would make for a profit margin would go back into the hospital to support buying new equipment, for salaries or raises, for example. And so we're not-for-profit, we're a 501c3, we can accept donations. If someone has something they'd like to, an estate or something they'd like to leave to the hospital, we can accept funds. Just some elements of a critical access hospital, and what does that really mean? Well, we're certified under a set of Medicare conditions of participation. So Medicare really is the one that determines if we're a critical access hospital and gives us that designation. It's very important to have that designation because we do receive cost-based reimbursement from Medicare, which is quite a bit different than if we were an acute care facility and Medicare would pay us differently. So critical access hospitals get cost plus 1% of what our care is. You cannot have more than 25 beds, and you'll hear from Jennifer's slide that we have 27, but we really have 12 acute beds, and then 15 are long-term care, which is a different designation. You cannot have an average stay of more than 96 hours, and that's on a yearly basis, so the average inpatient stay can be no more than 96 hours. You have to offer 24 hours, 7 day a week emergency care, and you have to be located in a rural area at least 35 miles from any other hospital. So that makes a difference, and that's why we're called a critical access hospital. Okay, and I'll turn it over to Jennifer.
Are you picking this up all right, Joe?
Yeah.
Okay.
So wherever you want to go.
Okay, I'm Jennifer Briner. I'm the Chief Nursing Officer at the hospital. I've been there for 19 years, and I've seen a lot of changes over those 19 years. And then I just wanted to start off with our mission. So the hospital's mission is excellence in healthcare services and the promotion of wellness in our community. So I think it's just a good reminder that we're here to make the community a better, healthier place, and it is the community's hospital. The services we are a 12-bed critical access hospital, a 15-bed long-term care facility. We have a 4 family practice physician clinic. We have a home health agency, and then a bunch of other ancillary services. In our hospital, critical access, like Liz talked about, it must be staffed 24/7 by RNs, and it has to have a physician on call within 30 minutes. We take care of anybody that walks in the door, regardless of, if they've been there or not, if they can pay or not. If you walk in, we will take care of you. Let's see. In our hospital, we have several different departments. Our emergency department, we average 2 patients a day. Of course, we might not have any patients, and we might have 8 or 9. It's an area that is not staffed unless we have somebody that needs to be taken care of. So the same nurse that takes care of the inpatients is taking care of the emergency room patients. Our inpatient area, we average just slightly less than 1 patient a day. And that can be anywhere from like a psychiatric admission to a pediatric admission to intensive care. So it's kind of anybody that needs to stay the night in the hospital, that's where they are. We also have a swing bed unit, and this is unique to critical access hospitals. We can use any of those 12 hospital beds as swing beds, which are for longer term rehab unit or overflow for long-term care. So if somebody is up in Bartlett and has like hip surgery and they need to have some PT and strength training, they can come to Petersburg for up to 100 days and receive the care or therapy they need in those swing beds. And we average about 3 patients a day there. We have outpatient also. We average about 1 visit a day, and these are things that are taken care of on the nursing floor by that same nurse. And these are things like chemotherapy, IV hydration, IV antibiotics, wound care. And again, we average about 1 a day. And then we also do surgeries. We have monthly GI scopes, and about every quarter we do some orthopedics cases. That averages about 7 per month. So you can see we have kind of a wide range of things we do in the actual hospital. In long-term care, I think it's important to notice that it's a completely different facility. It's different rules, it's a different license. It is a 15-bed unit. People often think that we're kind of combined because we share a nurse's station and they're in close proximity, but it's a truly like you're going from one building to another. It's highly regulated. It's one of the top, most regulated entities in our country. Over 800 regulations that we are to comply with. It is staffed 24/7 by either RNs or LPNs, and then CNA staff, which are certified nursing assistants, and then during daytime hours we have activities staff, which really help make the quality of our residents' lives improved. And long-term care people are called residents because it's their home. We average 14 to 15, so we stay pretty busy in long-term care. One interesting thing, our long-term care unit used to be full of local people who, had gotten older, couldn't care for themselves and moved in. Right now, about half of our residents are from out of town. Most of them were swing bed patients coming for rehab or different needs that ended up not being able to go home, and they have elected to stay in Petersburg because of the care they received. So anyway, long-term care is kind of our bread and butter, but it's that one separate entity. We have a physician's clinic. We have 4 full-time family practice physicians. We are very, very lucky that we do. They are well-trained and have a good variety of experience and interest. It's difficult to find family practice physicians. A lot of physicians are going into specialty areas, and it's really hard to find, and we're really lucky to have 4 that really love Petersburg. In addition to seeing patients in the clinic, they rotate emergency room call, take care of the hospitalized patients, and also the long-term care residents. In the clinic, they see acute and chronic medical problems, they do minor procedures, and they average right around 800 visits a month, and that can vary quite a bit by season, or if there's things out in the community that are bringing people to the doctor. Home health is our 3rd separate license. Home health is a very small part of our hospital. It's basically a one nurse-run department, and that nurse runs the drug room as well. But it is, again, a whole separate facility regulated by Medicare. Home health, you qualify for home health if you're homebound and you have a need that a nurse or a physical therapist that can provide. They do end-of-life care in absence of a hospice program in Petersburg, and I have to say that that's one of the most incredible services that our community has as end-of-life care at the patient's home. They do wound care, they manage medications, and then they have physical therapists that go into the home and help with strengthening and mobility training. They average about 1 visit a day. We have a multitude of really incredible ancillary services. We have our...
Can I interrupt for just a second? How does hospice care differ from end-of-life care?
It's the same type of care, but to have hospice, it's a separate. You have to have a hospice certification for Medicare.
Okay.
So it's just a different certification.
Didn't mean it.
Yep. No problem.
I just sidetracked.
So our ancillary services, we have a full-service laboratory, which is we are really blessed to have in our community. The lab does a lot of routine and diagnostic testing. They also facilitate uncommon send-out testing that we wouldn't be able to do enough to keep, it just wouldn't make sense for us to do it in Petersburg. They are CLIA certified and overseen by a pathologist. We're really lucky because of the amount of testing they can do on site. We get immediate results, and the physicians can diagnose and treat patients more quickly. One unusual thing that the lab does is they have microbiology on site, so they can do cultures, and they also do water testing for the Borough, and that is DEC certified, and they test the salmon roe for microbiology for the canneries. They average about 3,800 exams per month. And the lab, in order to do a patient exam, they have to assure the quality of that exam. So they do about 3,000 quality tests a month as well. So about 7,000 tests in total that they're running a month. They are open all business hours, and then they're also on call 24/7 through a call system. Radiology, we have a full complement of radiology. We have x-rays, CAT scan, ultrasound, mammography. It's a 2-person department. They rotate call, so there's 24/7 call as well as open all business hours. Some of the newer radiology modalities that we have, like CAT scans, can really be life saving. They can help the physician decide if a patient needs to be medevaced or if they can stay in town, and they've been really helpful to have. They do about 200 patient exams a month, and they are ACP accredited for mammo and ACR, and then moving towards their accreditation for CAT scan. So, physical therapy, we have 3 full-time therapists. We also have contract speech and occupational therapists who have to come from out of Petersburg if a patient is in need. Back to regulations in long-term care, if it's decided that a resident needs a speech therapy, we have to ensure that we will provide that contact or that visit for them. So then we have to contract with somebody to come to Petersburg to see our resident. PT does about 200 to 250 visits a month. And then we have all of our departments in the hospital. We have the business office. We have medical records, and I'm sorry that did not make it onto the slide. And medical records does the coding, and they keep track of the records and get the records to specialists and back and forth. We have human resources, which does a lot of background checking and safety checks because of all the regulations in long-term care. IT is a department that is growing more and more with meaningful use and just an increased use of technology in every part of the hospital. We have materials management, which must maintain all of our supplies that are current, and we have all these supplies that are packaged beautifully, and they have an expiration date sitting on them, and we can't use it after the expiration date, even though it's in perfectly good condition. So we have to always have the correct supplies available for any procedure that we will need to do. We have pharmacy, which, like I said earlier, is just a drug room. It's not a pharmacy per se. We stock about 1,000 medications. Some of them are very inexpensive, and some of them are very expensive to maintain, but it's important that we have them here if somebody needs them. We don't have the time to get it from a larger facility. And that is overseen by our retail pharmacist through a contract. We have a wonderful dietary department. We have a registered dietitian as well as the people who prepare the meals. There's a lot of specialty diets, and they know their preferences and the dislikes and likes of every resident, and they work really hard at providing nutritious and delicious meals. We have quality and infection control. They're working hard every day to make sure that we're meeting the standards of care. And then we have environmental services, which we could not last a day without. We have maintenance, laundry, and housekeeping that keep our facility in working order and clean and ready to be used. And then lastly, there's a few challenges that I face and our facility faces. We have, in that one building, we have 3 separately licensed facilities with separate regulations. If we were a little bit bigger, we would have 3 administrators, 3 directors of nursing, 3 quality departments, 3, And so we do all that with one person doing all those jobs, which is economical, but it also stretches us really thin, and we all wear a lot of hats and have a lot of jobs. The generalist nature of providing healthcare in Petersburg requires that we have education and training in a lot of different areas. We see geriatrics, trauma, cardiac, psychiatric, pediatric, and you can't just take a class that covers how to be a generalist. You have to take classes on how to do all of those different things. I think like anybody who is recruiting skilled professionals, it's very difficult to recruit and retain skilled professionals. We can't just take somebody who is a really good person and a good worker and make them a nurse or a doctor or a lab tech. It requires a lot of education and specialized education to do that. I talked about us wearing many hats, and then it's just really expensive to maintain essential supplies, including drugs, treatments, equipment that we are mandated to have. I mean, for example, the drug that we would give somebody if they were having a heart attack, it's a fibrinolytic, which is like a clot buster. It's our cost to us is $3,600 to just have it sitting on the shelf, and and it's there, and we luckily don't have to use it very often, but it needs to be there if we need to, and we need to have 2 vials because we might have 2 people in one night, or there might be a problem with one of the vials. So that's just one little example of those things that we have to have ready and available that are very costly and may or may not get used. So anyway, thank you.
By way of additional introduction, my name is Doran Hammett, and I just do interim finance work for hospitals around the country. And your hospital is my 13th hospital in the last 7 years. Those are primarily small hospitals, rural, critical access, and they range from, I've been to northern Maine to South Texas and Alaska now, and lots of points in between. So I think I can bring kind of a unique perspective since I'm enjoying being a resident of your community, but I'm not a resident of your community, so I can take an approach with what I see in your hospital that might be a little different than others. The first thing that I want to show you is this slide here. You certainly have some really, really good strengths. You have a really strong balance sheet. You have a strong cash position. You have a strong billing and collection on your accounts receivable system to where those numbers are kept in line. You have a very efficient operation, and we'll look at some slides here in a minute that point some of those things out. You have an excellent professional staff. One of the things I was most surprised about when I came here was that you had 4 full-time physicians. I've been in facilities where they struggled with maybe 1 physician, a nurse practitioner, physician's assistant. They had to bring in locums, which are very expensive. You're very, very fortunate among hospitals your size and in your location to have 4 full-time physicians. You've got a committed management. You have a board that's very engaged with what's going on, and you have a good community support. All those things lend itself to having a really strong facility, and I have been very impressed, comparatively speaking, to other hospitals I've been at with what you have. You tend to check most, if not all, the boxes off. There. I can't take credit for these next series of slides. These come from a group called the Flex Monitoring System, made up of the 3 universities you see there. They compile this data every year. We don't pay anything for this. It's just available to hospitals to use. And so it really brings some really strong points forward. And I've just pulled a few of the slides out so you can look at when we talk about you running an efficient operation. This first slide is Medicare acute inpatient cost per day. And these, the bars here reflect the Alaska critical access hospitals that reported data. The red bar is your hospital and what the Medicare cost per inpatient day. So this indicates that you are operating a facility that is efficient, trying to keep the cost as reasonable as possible. Okay. In the area of salaries, again, these are the critical access hospitals in Alaska. The red bar again is you as a percent of net patient revenue. Of all the hospitals in Alaska, you have the lowest percent of net patient revenue. Salaries and benefits typically take up 65 to 70% of a hospital's operation, and if you can keep those numbers efficient, you'll continue to do well, and you are. Okay. This data also compares you to what we call a peer group. Your peer group is a government-owned hospital, $10 to $20 million worth of net revenue, a long-term care facility, and no rural health clinic. You have a health clinic, but it's not a rural health clinic as under a Medicare designation. So these are hospitals all across the United States in your peer group, and there's about 25 of those. Of those, salaries as a percent of net revenue, you're in about the lower 1/4. So again, you have an efficient operation from the salaries and wages perspective.
How do you define a peer group?
A peer group is a hospital that has, it's a government-owned hospital. Your peer group is a government-owned hospital, $10 to $20 million worth of net revenue. It has a long-term care facility, and it does not have a rural health clinic. So these are very specific hospitals that look just like you at other places around the country. Another measure we use is how many full-time equivalent employees you have per adjusted occupied bed. Now, adjusted occupied bed is a measure that takes into account both your inpatient and your outpatient work. So it says of all the work we do, inpatient, outpatient, how many full-time equivalent employees do we use to provide that service? And for you, it's about 10. Then it goes up. You have another hospital that's close to 10, one about 11, one about 12, and one about 13. So as Jennifer said, you've got a lot of people wearing a lot of hats across the whole perspective of the hospital, and this measure is one that shows that you are pretty efficient with your employees. And when you look at the average salaries too, other critical access hospitals in Alaska, you're about in the middle as far as your salaries go. Again, there are a lot of very good things going on here, and I certainly have been in some hospitals where there were a lot of challenges. I actually have been in a hospital where I get a knock on my door saying, the guy's here with the linen, but he won't leave it until you write him a check. I've been in hospitals that operated on less than a day's cash on hand. I wasn't quite sure in 2 weeks if I was going to be able to make payroll. You're very fortunate. You are not in that condition. Your hospital is strong. You have almost no debt. You've got a strong cash balance. And so as of right now, of the 13 hospitals I've been at, I would say overall, financially, community, board, support, you probably rank up in probably the top one or two of the ones I've been at. I'm very, 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 very impressed with what I've found since I've been here. There are always challenges. You, unfortunately, because you are in a very remote area, there are going to be limited opportunities for increased revenue going forward. You're offering all the services that you can economically offer. We've looked at a few other things, but unfortunately, it's difficult to bring new services in when so few people are likely to use those services. There are even some services that you're doing now. Home health is one that you're probably not making any money on, but it's a service that we feel that the community needs to have, and it continues to be offered. Part of the reason we can do that is because the person who runs that also does something else in the hospital. If your personal budget or your business budget tells you that your costs are continuing to go up. The hospital's costs continue to go up. Inflation in healthcare, and you've seen all the news accounts, tends to be higher than a lot of other industries. So you're going to continue to bear increasing cost. Reductions in third-party reimbursements. The budget battle going on in Juneau right now could translate to less reimbursement. Medicare is always looking for some way, to pay you less money. If Medicare and Medicaid begin to pay you less money, the insurance companies are not too far behind. So there will be stresses on your reimbursements. As you have limited increased revenue opportunities, and as your expenses increase and as your reimbursements go down, that's going to result in a decreasing cash flow and decreasing cash balances. You're not in that situation right now, but it's likely that you will get in that situation sometime in the next 3 to 5 years, I would say. Maintaining appropriate staffing. Again, you're very lucky with your doctors, your nurses, your technicians, your therapists. You're as well staffed as most of the hospitals I've been at. But there are challenges going forward. Doctors retire, nurses move on. We're almost in a constant recruiting mode because we always have some turnover, and those positions need to be refilled. Aging infrastructure and equipment. There's a measure that hospitals use called average age of plant. In other words, what is the average age of our facility? Not just the building, but the building, the improvements, and all the equipment. The average age of plant of all hospitals in the United States is 9.83 years. This graph shows average age of plant for the other critical access hospitals in Alaska, and you're currently approaching nearly 20 years. this will, down the road, cause you problems. Go ahead and show the next one. The next one is your peer group. Of your peer group hospitals, of all hospitals that are in your peer group across the United States, you have the third oldest aging plan. As I've looked at this, I would say that I don't have a particular problem, I think, with you maintaining the facility on a day-to-day and a month-to-month basis. All the routine repairs and maintenance. We currently spend about $250,000 a year in just routine maintenance. Now, that doesn't include if you added a new stack to your boilers. I think it was. You're in the process of installing a new boiler. That doesn't count those kinds of things. But just the day-to-day operational maintenance and upkeep, I think the operation of the hospital over the next few years won't have any problem maintaining that. My concern for your facility would be some sort of catastrophic failure. You have a water line that breaks and floods a large part of your hospital. You have a sewer line that collapses and you can't expel sewage from the hospital. You have a electrical panel that burns out, and events that might shut you down for a time period. And for your finances, that would be a very difficult thing to overcome. So again, I don't think you have a problem maintaining on a month-to-month basis operationally. I just have a concern for a facility that its average age is 20 years, and that's including all of your equipment and all your improvements, that you're going to have to face how you're going to address that. And certainly it's this community needs to look at and decide what does it want healthcare to look like going forward, and what do we need to do to get there. And it's obviously a community effort. Everybody has to be involved and at the table. There's no doubt you want health care here. If I was a teacher and I was looking at going to two different communities and one had a hospital and the other did not, which one am I going to go to? But again, let me back up. Right now, you have a great facility, you have great staff, great doctors, board, community involvement is good. You have strong cash position, don't have any concerns on a day-to-day basis going forward for the short term. However, I would think you would need to be concerned over the next 3 to 5 years what you need to do. And unfortunately, you can't wait 3 to 5 years to start talking about that, because whatever you want to do is going to take that period of time to get there. I think that's my last slide. Yes, it is. Thank you.
Thank you. Go ahead, Chad.
Excuse me. Just as a board's perspective, I'm going to try and wrap up a lot of the different things that they've talked about into what we think about. And, you know, the first one that's come out a number of times is just the excellence of care that we have here, and how lucky we are to have the organization. I'd also say that the care that we provide is very, very much dependent on the staff of a bunch of dedicated individuals that take their responsibilities really strongly. And in terms of the facility itself, Doran's touched on its age, and it does have some constraints. For those of you that have taken the opportunity to have Mike show you around, in a portion of the old hospital, you've got exposed sewage pipes and stuff like that, and electrical panels for many of the potentially high electricity needs aren't there. So you'd be rebuilding panels and things like that if you're going to do some of the expansion in the facility that probably needs to be done, or improvements. Go ahead, Chad. Reality, the way I look at it, in particular after the 6 or 7 years that I've been on the board, is the population of Petersburg really isn't growing, and the population looks like it's aging a little bit, and it looks like the young folks are a little bit more transient, which brings in the seasonal economy issue. We see it at the hospital in the cash flow issues, the seasonality, and so it's there's always a period of time, sometime after December, until fishing season goes away, where we look at the cash flow issues pretty closely within the hospital. The seasonality thing also, or the increasing cost of care, is sort of tied together, and the increasing cost of care that's going to happen by regulatory changes those are going to be borne either by the state government, the federal government, the community or the insurance companies themselves, or it's going to be borne by the patient. Or in our case, where we're required to take everybody in, there'll be certain losses that we're going to have to absorb for people that are not insured. We don't anticipate an increase in service line. The medical staff and what we call the C staff, the CEO, the CFO, the chief of nursing, have all looked at this and said, well, what else can we add in? And there isn't much that we think we can do. Grants are becoming less available, as we found out when we remodeled the clinic, both from the state and federal side of the house. And a lot of communities now, and Liz can talk about this, actually are receiving operational funds from the cities and boroughs that they work for. Sitka is the one that comes to mind to me instantly, but I know there's others. The challenges, the regulatory requirements are going to continue to increase with cost. Staffing is an issue for me. When you look at it's good that we're efficient in terms of our cost per bed and things like that, but that also, if you're a nurse and you want to come from Texas and you look at this data that's available nationwide and you say, well, their pay scale is down lowest in the state of Alaska, they may decide that they're going to go someplace else. And it's very difficult to get a professional in, whether it's at the nursing level, the doctor's level, and then expect to train them to what you need. They need to come here pretty well trained. We can help, but we can't solve that problem. Electronic medical records have added a whole bunch of issues to the regulatory requirements. I don't know where we are right now, but I think the initial outlet for electronic medical records was about $1.4 million. Now we're required to keep data for 21 years for young kids. We've had 3 different electronic medical record systems, and then you're paying a programmer or whatever to continue those things, update and make them available. And I think Joe said the last update was $14,000 just in the programming of it. On the staffing side of the house, we've got to maintain this high standard of care, which is, as Jennifer said, is in our mission. It takes a great amount of dedication for a nurse to work a long shift, particularly a night shift, and then have to do continued education during their normal work process. So that's something that's a challenge. So attracting, hiring, and maintaining the quality staff is hard. As Doran said, we're strong today, and maybe we're looking for that 3 to 5 year window where we're going to be fine, and then it's difficult to look beyond that time frame for a number of reasons. One, the economy. One, what happens in Petersburg demographically, and then what the regulatory agencies are going to do to us. I guess the other challenges related to the facility, I spoke to some of that before, is that there are 3 different major sections of the building that were built at different times, and the oldest section is very aged. And that's where the long-term care folks is now, which is about 60% of our income. And so if we think that the community is going to age and there's going to be more demand on the long-term care part, that's going to be an issue. And we already know that we've already had, since I've been around, a couple of deficiencies in the building. The latest was in the shower room for the long-term care, so we're going to have to build a shower room that we can use for the long-term care patients and then rebuild the old shower room. So in essence, we'll have 2 at the end, but it's a cost. Next one, Chad. Near future needs. The way I look at it, we need to increase salaries and benefits and training if we want to maintain a professional staff that's competitive with other people in the state or elsewhere in the U.S. We can look at the increased staff levels as it improving our health care. Even though we're very efficient right now, I think there's ways we can look at the staff levels, and I don't think there's any doubt that if we had the opportunity to get in a couple of more registered nurses or something like that, we'd probably jump at the opportunity to hire those folks. So yeah, sustaining and increasing the staff to maintain the quality standards is something that we have to do. I already talked about the priorities in terms of long-term care facility right now. It's the shower room, but at some point in time, standards are probably coming down the road on long-term care facilities that are going to demand single rooms. And that's going to require some kind of a significant remodel of the hospital, or think about another annex or something like that. Okay, Chad. So the long-term needs, and this is sort of beyond that 3 to 5 year window that we're looking at, is, but the planning is going to have to be during that period of time, is thinking about a long-term care facility or an annex that's separate from the hospital. That's one option. Or developing a whole new option with a whole new hospital with various wings that would accommodate the current standards. So, next one, Chad, please. So I guess the way we look at it as a board, we're proud of the hospital, and it's critical and essential asset to the city of Petersburg. And but it's not going to be a static. Hospital today or for the near term tomorrow. So the way we look at it, it's going to need improvements. Those improvements are going to require coordination, planning, resources, and a priority of commitment. And if we defer the solutions and kick the can down the road, as they do in Washington, D.C. all the time, all we're going to do is increase the magnitude of the problem that we're going to have at some point in time. And to date, we do have a foundation, but to date, that foundation doesn't have the ability to help us out in capital improvements. It's used for scholarships and increased training and things like that. So the revenue that's coming in from that is allowing us to continue to give people scholarships and continue to give people training opportunities outside of their normal operational costs of the hospital. But it's not capable of providing capital for facility improvements or replacement. And I would say that some of the funds that we've received through the foundation were received very pointedly. So there are certain things that the state or whatever that tied to those funds that they gave us. And they're invested very, very conservatively. And I don't know exactly what they make in a normal year, but the board talks very specifically about how many scholarships and things we can give out. So, and a lot of those scholarships have gone to local people that grew up in Petersburg and went out and got their education and came back to town because they liked the family approach here, and they liked the standard of living in Petersburg. So the board is going to have a strategy session on the 2nd of May that you guys can certainly participate in. It starts at 9 o'clock. And of course, you're always welcome at our board meetings. And Kathy and Marlene just got back from a annual conference on rural hospitals in Phoenix. And if you ever if you really want to see how complex these things are, it's a good thing to go to. But I've been once, and I would like to go again. And invariably, when we ask particularly the people from federal government agencies what we're looking forward to, there are no answers. They can't really tell us. And so it's hard to anticipate what you have to do in the future. So I think the challenges are going to be there, and they're going to increase in the healthcare arena. And we've got a number of references we can give you if you want to look at some of this information independently. You have those first ones up there, our audits and board minutes and work sessions, and the critical access financial indicators come from the Flex monitoring team. And if you get into that website, there is a website that you can find, and I've got it. I don't know if we put it on the. We did not. But Chad can get it for you, and it's got like 4 or 5 pages of introduction to it. Bob, you asked the question of what is a peer group and how they analyze the data and collect the data, and of course it's very independent of us, but it's something to look at to give you a metric of what Petersburg Medical Center is doing. And then this Kaiser Health News has got some very interesting things. It's a really easy website to get into, and they recently did a couple of articles. One was what happens when a critical access hospital closes in the community, and it was an actual case. I don't remember what state it was in, but the first thing that does is all the professionals in the community leave. And then there's another article about 721 violations or something that have occurred in hospitals that I kind of like to look at. And there are two in Alaska. I think they're both in the Anchorage Bowl area, weren't they, that had violations this year? But, so anyway, that's what we want to present to you, and thanks for the opportunity for the interacting and for putting it over the air for the public. That's good, and we'll entertain any questions you have that we can answer.
Any questions? I'd like to ask that you send out an invitation closer to like the end of April about your May 2nd meeting to be reminded. That would be, if you have time, would be
Absolutely.
interesting to partake in. As we know, we're all going to be in difficult times with finances. People we've been used to getting money from for capital projects, and it's going to take a community effort to keep, I think, the level of life in Petersburg. And I don't know how we're going to approach it when the state starts cutting 50% here, 60% there, and that's this year. And next year they're going to do the same thing for these different funds, from police funding to what have you, education, and so got a tough road ahead of us. But I'm glad to hear the positive news on how the hospital facility seems to be sound and promising for the near future, 3 to 5 years. But it sounds like it is time to put our heads together and start planning.
Yeah, and one way to think about it monetarily, Mark, if you take, say, they decide that they want to cut 1%, out of the reimbursement for, say, Medicare, and I don't know, I have to go back and figure that out, but it's going to be hundreds of thousands of dollars for us.
At 1%.
Just at 1%, yeah.
Can I ask what you're hearing from the state about reductions in funding? I know what we're hearing, but are you?
You want to talk a little bit about the Alaska Hospital Association?
Right. Well, our hospital and all the other hospitals in Alaska were part of the Alaska State Hospital and Nursing Home Association. And we just had a meeting in Juneau 2 weeks ago, and we were talking about the big issue, of course, is the Medicaid expansion. But along with that, it would increase Medicaid from 100% to 138%. But the issue is, if that ever goes through, they want a lot of reform, Medicaid reform. And that would mean that the providers, in our case, would be asked to take cuts in reimbursement. There's been talk about a provider tax. There's been talks about getting rid of the, at the federal level, the cost plus 1%. And that would make a huge difference for us. So there is a lot. And then the Cadillac tax. Everybody, are you familiar with the Cadillac tax that's on health insurance companies? It's not just for hospitals, but if you have, if you employ over X amount of people and you provide health insurance for your people that's considered above the very basic minimum, there's a tax. And the Homer Hospital did an analysis in Homer. If the Cadillac tax goes through right now as planned, it would have a negative effect of $1 million on their hospital loan. So that's coming down the pike in 2018, unless there's some reform to that. You've probably heard about it, Stephen. So there's a lot of concern at the state level and, of course, at the federal level about healthcare reimbursement. And then there's also a lot of different models of care that are being talked about as far as healthcare reimbursement. So, for example, one issue is like a managed care, and where maybe the insurance company or Medicare or Medicaid would pay a hospital doctor, for example, X amount of dollars per month, $5 or $10 per month, to manage the care of that patient. But the patient's, with the patient's goal of being prevention versus, taking care of chronic conditions. But they're asking the hospitals and the providers to take a lot more risk And the whole managed care era of the 80s and 90s was pretty much a dismal failure because people don't always lose those 10 or 15 pounds that you tell them to do or quit smoking. So you're taking a big risk. And so you're getting reimbursed based on the person versus maybe the condition. So there's a lot of worry out there about changing reimbursements.
Thank you.
Any other questions of John?
I said, and this may happen in, be one of the reasons for your May 2nd meeting, are you developing your staff sort of a defensive strategy? If A happens, then we'll go to B. If, you know, like if you get the 1% cut in Medicare, then we'll follow our reaction will be Plan B, or if this Cadillac thing comes through, then we have a way to compensate for it. I don't know. It just seems you seem to know all the scenarios that are possible, and I didn't know if there's a developed plan to meet those.
Well, I think it has to be done in concert with the community, because what would happen at that point if something catastrophic happened, and you know, both Tim and Doran addressed the fact that it will happen that our cash will become less and less over the next 3 to 5 years, and if something really changed with the payer mix or funding or the Cadillac tax, I think in concert we'd have to work with the assembly and the community and the citizens to determine what types of healthcare services you would really want. Because we, as you could see from the slides, we're already pretty much at the most efficient, effective staffing and service that we can offer. So it would have to come down to what would the community want. It really would have to be a community effort, and that's why we really want to partner with the assembly. Is that you know, the borough does own the building, and you know, if something happened, you know, to the building, the operations of the hospital would be at risk. And so I think it would really, that's why we want to do strategic planning now, and kind of think about long-term plans like, you know, do we want to remodel the building? Do we want to have a new hospital? What would we do if X, Y, or Z happened? We could not really just say, okay, we'll take a 10% cut across the board and keep the same services. It wouldn't happen.
No, exactly,
Yes.
and that's why I was
Yeah.
wondering if one of these scenarios happens,
Mm-hmm.
you know, you come to us and say, okay, this is the hit, we have option A, B, and C, what's your preference?
I think we would develop those, and yeah, I think we would, and that's why we want to just start this conversation and work together with, you know, the assembly and the community as partners, because we all are committed to health care, and we all plan to live here, and we want to continue to have good services. So it's a beginning dialogue, I think, and that's why we would welcome you at our annual retreat, our strategic planning retreat.
I guess I would add to that, John. The first obvious thing, if it's us managing the hospital, you know, is since 2009, 2010, we put about $2.1 million into the building itself. The new roof, the boilers, all the other little ancillary things we put into it. That's money that I guess that we could have, if we could have held it back somehow, you know, and used it for a future fund or something like that. I don't know exactly what the rules are in a nonprofit organization. You can only hold them so long. We would come to you guys and say, well, you know, maybe you're going to have to pick up those costs in the future, because something of each of the 6 years I've been on the hospital board now, something always happens within the building. And Mike's the expert. He can tell you what's going on. And then the other one that's obvious for us is we could save ourselves, you know, $250,000 a year if you guys picked up all the maintenance costs that we're currently doing. And so we would look for those sorts of things that we're sort of paying for now out of our operational funds, that we could maybe better use those on the healthcare side of it rather than the, you know, the maintenance side of it.
Unfortunately, there's not a lot of room in your budget currently unless you begin to cut services.
Yeah.
Say if you've got really desperate, maybe you cut physical therapy and don't provide physical therapy services and take those salaries out. Fortunately, at one level, at the federal level, critical access hospitals have generally been pretty insulated at the federal level. It's a very, very small part of the overall Medicare budget, and representatives and senators in rural communities really have kind of protected that. But Liz mentioned we get 101% of our cost for providing Medicare services, but that's just 101% of the Medicare patients, the cost of treating Medicare patients, and that's only about a third of our patient volume is Medicare. And so it's not 101% of the entire hospital cost, but just treating Medicare patients. So if you had a major issue where you lost a funding source, there's some really hard decisions that would have to be made going forward.
Right.
You know, the manager and I have, and maybe we want to expand on this a little bit. We've been having discussions about the, you know, how to approach, you know, the financial conditions of facilities in town, hospital, school. He's reached out a little bit to the superintendent, and I assume he will Liz too, and maybe the community as well, and start getting community involvement, get a committee from different people from around the community to put our heads together and try to figure out where to go. Is that kind of an approach you're looking at doing, Steve?
Here's what we're facing as a community. Borough right now, as of today, and the legislature has not finished what they're doing, we're down about $1 million in revenue. Okay, that's a combination of federal secure rural schools as well as state changes that they've done. You know, if we just pretend for a minute and say the hospital needs $500,000 a year from, you know, added revenue from someplace, add that to my number I just gave you, we've got to come up with $1.5 million in revenue or expense cuts. The borough's actually starting the expense side of it because we're pretty much have to at this point. But, you know, 1.5 million, you know, what's that, 8 mils, 9 mils, give or take, in property tax, or change in sales tax, which did not go well at the last election. You know, you can start to see the numbers. So I've got a meeting scheduled with the school. You know, I want to make sure they're on board, but it's going to come down to literally getting the three organizations together, starting off with a, you know, where do we head here? What does the community want? And then, you know, as the mayor suggested, you know, maybe getting a community group together and say, okay, folks, we need $1.5 million, whatever that number is, in either expense cuts or revenue. How do you want to go about getting it? Because all of that has to go to the voters. So we can't raise the mill rates enough to cover that. Sales tax, we tried with the voters and that failed.
You're at the cap right now.
We are 1 mil under the cap right now. So, and as I think the mayor, you heard him say earlier, we're being promised that next year's budget cuts by the state legislature will be even more dramatic than what we've got this year. So is it really $1.5 million, or are we talking about $2 million? Okay, so that's the community conversation, and I'm not sure how well that'll go right now. That's, you know, I kind of wanted to get a feeling from the school. What we're hearing is they can't cut anything, and that the community tends to back that at this point. So cuts are in. You know, what I heard from the hospital is similar to that. So what we're looking at is cuts in borough services and some form of revenue solution. And again, I don't have an answer for that yet. So.
I do have a question, if I could.
Sure, Steve.
The tobacco tax. Where's that money going?
Assembly voted to have that go directly into the general fund. And we don't yet know how much that's going to generate. We haven't got our first check yet, so to speak. We budgeted for all of next year $200,000 in revenue for that. We'd hope to have that available for various things. Since that time, the state has cut community revenue sharing and the community jail program, and that's where we stand at the moment.
And so I could,
Yeah,
I know
sure.
there's a lot of, there's these cuts, and yeah, we have to deal with it. My issue is the hospital, and I've only been on the board for, 9 months, a year or something like that. I don't know what was going on in the past, but every time I read in the paper or anything, everybody's getting a certain amount of money, and it's always a big goose egg for the hospital. And then being on the board, and I've been from the roof line down to the boiler room, and I've been through that hospital. And we do have an excellent staff. I mean, you couldn't have better, from the CEO all the way across the board. I mean, they really care. I sit in there and just watch, and I've been there a lot. But I watched the building and going through like the shower room and all these different things that have been on for a long time but not getting taken care of. Now we're going to start a discussion when we don't have any money. And to me it feels like it's kind of, for lack of better, we really have to figure out what we're going to do as a community. And the hospital needs a break at some point. If nothing more, just having the heavy hammer of the borough behind us. So when we go and have a lawsuit like with the roof or something like that, at least we know we're being backed by the assembly. Not even asking for money, just, hey, these guys are having a problem, and the borough of Petersburg is behind you, and signing with us when we have to go deal with different things. But back to the funding part, the community, yes, we need to figure out what we're going to do, and we've had this comprehensive plan going on, right? And I've been reading and listening. Through the comprehensive plan, and the average age is continually getting older, right? So for a community that's 3,000 people and getting older, then that's one reason for more health care. But then the other thing is that if we're trying to entice and try to keep young families and people here in the community, then just like Norm was saying, you're going to look and say, do you have a hospital? Am I going to want to move here with my family? No hospital? No, I'm probably going to go here then. Or, how strong is this? Keeping people here, trying to get less transient in the younger generations and try to keep people here more. These are some of the concerns that I look at as a person that, I'm 38, but, I feel like I'm somewhat younger and just growing families and being here. So
I think you've got very valid concerns. It's one of the reasons the Assembly, tried to get some of those sales tax changes done, and they failed miserably.
Right.
Let's call it what happened. The community voiced their opinion very loudly, and you just take the senior citizens sales tax exemption. That goes up every year, and when I say goes up, what I mean is we receive less revenue every year because more people use that exemption. So our revenue is actually declining year over year for that very reason. You're right on the comp plan. That's one of the things they quickly focused on, is they see the same thing we did, which is the aging of the community. Going to need more health care, but they're also going to get more off their property taxes because of the state's mandated property tax exemption, and they're going to get more off their sales tax because they'll be exempt from that.
And you don't get that money back.
And we don't get it back. So this is a big problem. It's been there for a while. The price of oil has made it front and center, as many of the other programs. Our law enforcement is now being affected with the community jail program. We just took a $300,000 a year hit to that. So we're going to have to talk about how many officers can we afford to keep and have on staff. We're already talking about changes in the hours at the library and the hours of Parks and Rec, and it's not going to change. I can't see an end to that direction at this point.
I have a question. What about the additional funds that are coming in from the borough properties that have been annexed?
If it wasn't for that, we'd be in a pretty serious problem right now. Like I said, we lost over $1 million in revenue, and we're not having to raise the mill rate to make up for that. That's exactly where it went. We 400 and some thousand in property tax, couple $100,000 in sales tax, and the secure rule schools went up. Of course, now disappeared totally. PILT went up a little bit, and the net result is we were able to put a balanced budget on the table next year with some cuts to the borough, particularly in Parks and Rec for this upcoming year, and the following year to the library project. But if it wouldn't have been for the borough formation, we'd be looking at some pretty major cuts right now, or changes to the tax rate to try to make up for it. And the state cut, we went from $535,000 in community revenue sharing to about 200. Community jail program went from 300,000 to, we're not sure we're getting anything, but we're budgeting 200,000. Secure schools is we get 1.3 million. We got $9,000, and what they told us in Washington is that program's done. So that's the school at this point is being held whole, and we're making up for it in other places. But we can only do that for, I need Jody here, but I think it's about 4 years, maybe three or four.
That depends on how big the cuts are from the state, too.
Yeah, and we don't know what that's going to happen yet. We're hearing rumors the state's going to raise the PERS and TERS both contributions for all employees that are in PERS and TERS. That hasn't happened yet, but we're pretty much expecting it. And then the following year, my guess is community revenue sharing will basically cease at that point. So another $500,000, give or take. So that's literally what we're all facing right now. The borough doesn't, there's not extra money other than tax and going into reserves to balance an operations budget, and we're now in the mode of cutting expenses and not replacing employees as we lose them.
One thing that I did not share with you is in 13 hospitals, the number one problem that I've seen with all of those hospitals is that they failed to respond quickly enough to the changing landscape.
Yeah.
It's what I would term the sun will come out tomorrow syndrome.
Yeah.
By you getting this meeting started and by committing, it sounds like a commitment to me, to work together with both boards and the community, you're way ahead of the game, because at least you're starting the conversation about what the issues are, what the potential is. Unless something major happens with the hospital, I think financially it can do well for the next at least 3 years, unless something very difficult comes along. We understand, and I'm sure the board understands, the financial condition that the borough is looking at, but getting the conversation started, moving this down the road to some place where, as a community, you decide what do we want in healthcare and what can we do to get there. You're going to be ahead of 90% of the other hospitals out there, because you do not want to start a downward spiral. I've seen some hospitals that go on a downward spiral. The first thing they do is they start losing their professional staff, because those are the people who are most mobile and they can move. And then, it's kind of like a whirlpool. The longer it's there, it gets faster and faster, and eventually I've seen hospitals that just simply, you would never recover no matter what you did. So starting the conversation and moving it down the road is going to put you in a very good position to
It's going to be definitely a community level decision, because unless somebody's got brilliant ideas that they haven't shared yet, we're not going to cut our way out of this. There's not enough money there to cut to get everybody solvent. So it's going to have to be a revenue solution, and that means taxes in some fashion, whether it's sales tax or exemption changes or property tax changes. And none of that is popular here in Petersburg. And I don't want to sit here at the table and make promises to the hospital or the borough or the school that I've got some brilliant idea on how to fix that. I mean, we tried that with some of the changes we wanted to make to the sales tax, and it did not go well. And I have no reason to believe it would go any better next time. So, somebody's going to have to come up with a better idea, I guess, than changing sales tax.
John? Steve, I've been going through some of the emails you've been sending to keep us on top of this. And one, I wanted to thank you, because I really appreciate you being on top of this and starting these discussions and us having this meeting tonight, because we do need to plan for what's coming, because it's a nasty hit. I was here in '85 when tens of thousands of people lost their home and their jobs. And at least this time, the state has a bit of a savings account, so it's a bad hit, but at least, we've got a little bit of time to make up for it. And I think the state's going to look at the same things we're looking at, is a sales tax, property tax. When I was here in '71, and I forgot what the tax was, they did it on your cars and boats.
Personal property tax.
Personal property tax, thank you. And an income tax, a payroll tax. So I think the state's going to be looking at all those too, and so it's even going to make our options a little more precarious, because if the state's hitting us with those, and then locally we're hit with those. But it's nice to see you being proactive and having this meeting here too, because we have to tell the community, if we don't raise this, then this is going to happen. We lose this service, or we lose this program, or we lose the pool, or the library, or, we're definitely going to have to cut back majorly on a lot of these things, the hours anyway, but it's nice to give the community the option of saying, you either help us this way, or this is the cost. And if they want to pay that cost, fine. If they don't, then we don't have any options, But it's nice to have that laid out so everyone could see what happens, rather than just say, we'd like to, which didn't work, we'd like to get rid of the sales tax.
Right.
Yeah, that was.
But I came from a community. And anybody who's ever lived down in the lower 48 can relate to this. A community of this size in places like Texas and Oklahoma and Kansas and New Mexico isn't as nice as Petersburg. And I'm not just talking about pretty mountains and trees. I'm just talking about basic infrastructure. I live in Oklahoma. I live very close, 10 miles from your border. But I think you echo that. Most communities of 3,000 people do not have the kind of infrastructure that we have and the quality of life that here. The hospital, the pool, the library.
It's true.
Our mill rate there in my friendly little town in Texas was about 4 times higher than what it is here in Petersburg. Okay, that's an example. And what you get for 4 times more is not even 25% of what Petersburg offers to people. But try to convince people that live here and have paid, less than 10 mills their entire life is going to be a really rough sell. I don't have a great answer to that quite yet.
Unless we can add marijuana testing to the Salmon Row testing, we might be able to pull in some revenue there.
Maybe.
We need a different building.
Maybe.
We are fortunate, though, that the state has 3 years of money to operate at a $3.5 billion deficit, and without tapping the permanent fund. And I think they're waiting to address that until people start feeling the pain. And then they're going to put that conversation on the table as well. So,
and what did Governor Walker tell you, Mark? Let's see. If oil went back to $100 a barrel and the state cut its budget by 25%, it'd still be upside down in the state's budget.
$500 million a year.
Yeah.
$500 million a year.
At oil at $100 a barrel and cutting 25% of the state's budget.
I've always looked at it, Steve, like the oil flow was the state's equivalent to the federal government printing money, and increasing the debt to 18 billion. Instead of facing the realities of what you could live with and maybe slowing down some of the development, we just continued to spend money and spend money.
We were able to, and notwithstanding being able to give something to the hospital, but we were able, with the borough formation things, we were able to absorb the cuts the state hit us with and still put a balanced budget on the table. Now it cut into, we usually budget money for contingencies, that's gone. And, we wanted to put more money towards this building to try to get the police station squared away, and that was taken out. But you know, that's going to be the big story, is down the road, how do we, you know, if those kind of cuts continue, we're not going to be able to withstand that. I mean, we were able to use the added income we got from the Borough formation to offset it, but that's a one-time only. I mean, that's the operating money now.
Well, way back when, I mean, that, one of the other things that's changed, I mean, we wouldn't have a hospital if it hadn't been for some of the older families in town who took their chainsaws and cut the pilings and basically built the hospital.
Yeah.
Now we're in a regime where we're used to taking from the government rather than helping the government out, and that's a whole different mindset that you've got to contend with.
It's going to be a big challenge. I mean, like I said, I meet with the school when I get back from vacation just to make sure I'm on the same page with Erica and the school board. And you know, I think I'm safe in saying that probably from the hospital's perspective as well, we kind of need the school on our side. They're very popular. So, I mean, just call it what it is. You know, folks love the school here. We need them to stand up there at the podium with us and say, everybody, we need this.
Well, I think the important thing from the community's perspective is to identify the qualities of life that are most important to them in Petersburg, and that's a conglomeration of a number of issues besides the rain, you know, that you have to identify and talk about. And if you can't come to some consensus on the important qualities of life in Petersburg, then you are on that downward spiral that Doran's talking about.
Yeah. I mean, yeah, we heard stories that, I mean, we can do this all night, but it's, you know, communities that had borrowed against their secure rural schools a year in advance. That's all they have for school. And they borrowed against it, assuming the money would come in and the program's canceled. I mean, and this is all over Oregon, all over, you know, Montana and Wyoming and Arizona, where that's their sole source of funds for their school districts. You know, predecessors to me and, you know, courtesy to the Assembly and the City Council, they put a lot of that money aside so we can keep funding the school as is, you know, out of that fund for, you know.
School board was very instrumental.
3 years, 3.5 years, yeah.
Plan.
But at the end of that, the school's going to take a $600,000 a year cut in funding. And, you know, that's what we're scratching our head about right now. I mean, just trying to make sure we've got a replacement for that in 3 or 4 years, let alone trying to get something done for the hospital. You know, we can't afford to lose your jobs. I mean, it's just, take it to pure economics. It's not just about the hospital and somebody to tend to my cough. It's the fact that all those very nice paying jobs that don't exist anymore, that don't buy things at the grocery store, and I mean, it does hurt.
Part of the economy.
It's the same deal. That's all I have to say.
Well, any other discussion about this fun topic?
No, I'm pretty depressed. I moved to adjourn.
I would say, if anything else, like, just, if nothing else, like, just having the assembly behind the hospital when we send out letters or do something when we really need a hammer, it's there.
I'm not sure that it's ever been asked, but I don't know why you would get turned down for a support letter.
Maybe not. But I'm just saying that would be.
We definitely need to be working more in unison, I think, as we go forward. We're lucky we have a little bit of a cushion. In the 80s, when the state ran into this issue, like John was saying, there was thousands of people lost their jobs. It was, could actually afford to buy a house in Juneau.
If you wanted to.
If you wanted to. So, all right, without any objections, I guess the meeting's adjourned, and we will keep in touch.